the first case. So we have a 47-year-old man who asks you whether he should be screened for diabetes. So the question is asking about the indications for screening in patients with diabetes. He is asymptomatic and he doesn't have any past medical history of note. He's only taking daily multivitamin, omega-3, and calcium. His family history is negative for diabetes. So what would you like to tell him, given the fact that his blood pressure is normal and his body mass index is 24 kg per meter square? What, when should you screen this patient for diabetes? Now, at the age of 50 years, only after he develops cardiovascular risk factors, only when the BMI becomes greater than 25. Remember, he has negative past medical history and he's a 47-year-old man. What do you think is the correct answer here? Let's wait for the poll. Dr. Abbas, can you start the poll, please?
Yes, Dr.
This question is discussing the details about when should patients be screened for diabetes. Of course, this is commonly faced in the exam. We don't always remember this. We usually send everyone, but it's very nice to know such questions. They do come up in the exam quite often. You have 1 minute for each question. Okay. So now let's see the correct answers. So the correct answer is now, as most of you have suggested. This is very good. Some of you have suggested that only when patient develops cardiovascular risk factors or only when the BMI exceeds 25. So let's review the ADA recommendations for screening. Of course, first of all, testing should be considered in patients who are overweight or obese. Of course, the BMI is 25. They use the BMI as 25 in most individuals, except in Asians, Americans, where the BMI is 23. So this is important to remember. If they have any of the following risk factors: first degree relative of diabetes, high risk ethnicity, history of cardiovascular disease, hypertension, if the HDL is below 35, for women with polycystic ovary syndrome, for patients who are sedentary lifestyle, or other clinical conditions associated with insulin resistance like severe obesity or acanthosis nigricans. Number two, patients with pre-diabetes should be tested early. And number three, women who are diagnosed with gestational diabetes should be tested every 3 years. Of course, this question came up in the exam a few years ago. They brought a female who has recently delivered and she had gestational diabetes. And the question was, when should you test this patient? And the answer was every 3 years. So this number is important to remember. As I explained to you, whenever you have a pregnant lady, then there's a problem with the question. For all other patients, testing should usually begin at the age of 45, like our patient here, who has nothing of note of the above mentioned points. And if the results are normal, then you do it every 3 years. So these are the important things to remember about screening patients with diabetes. So let's go to the second question. We have a 54-year-old man who is referred for your management of diabetes, and he has had diabetes for 4 years, and he's been treated with metformin 1 gram twice daily and glimepiride 2 milligrams twice daily. He also has hypertension treated with ramipril 10 milligram daily and dyslipidemia treated with atorvastatin 20 milligram daily. Moderate non-proliferative diabetic retinopathy was diagnosed at his last eye examination 8 months ago. He has a history of multinodular goiter, which was revealed to be benign FNA 2 years ago, and he has no concerns except that he was unable to lose weight. So this is his major concern. He wants to lose weight. On physical examination, the blood pressure is normal. The BMI is elevated. He has grade 1 obesity with a BMI of 32 kg per meter square. He has goiter with the left dominant nodule, approximately 2 centimeters. So let's review. He is a typical type 2 diabetic patient in his 50s. He is taking metformin and sulfonylureas, and he wants to lose weight. And he has a moderate non-proliferative diabetic retinopathy and a dominant nodule with 2 centimeters, which has been evaluated, but it was negative. You check his labs, and you find the A1C is elevated at 8.7, and the creatinine is normal, everything else is okay. So you decide to start a GLP-1 with once weekly semaglutide. So the question is, of course, this question can be also mentioning liraglutide, which is Victoza, or it can also mention lixisenatide or other GLP-1. So this question applies to all GLP-1. Which of the following should be done at the follow-up visit, assuming that he remains asymptomatic? Amylase and lipase, calcitonin, liver function test, creatinine measurements, eye examination. Remember, this question is about dealing with patients starting on GLP-1. How should you follow these patients?
عفوا دكتور ثواني وتشير البول.
البول اوكي.
اوكي اشتغلت تمام.
ايه البول is fine. Okay, so most of you think that you should send them for amylase and lipase. Okay, 4 of you chose the correct answer, which is to do an eye exam. The most important thing to do here is an eye examination. Why? As you might be aware that lowering blood sugar rapidly with insulin can worsen diabetic retinopathy. And if you remember that our patient here had moderate non-proliferative diabetic retinopathy. The same thing can happen when you start GLP-1, which can rapidly control the blood sugar of patients, which would subsequently result in worsening of diabetic retinopathy. And this actually was seen in the SUSTAIN study when they evaluated the effectiveness of semaglutide, and they found that the hazard ratio here for retinopathy was much higher in the group who received semaglutide compared to the control. So this is an important thing to remember. When you start a GLP-1 or when you initiate insulin therapy in patients who had a background, or especially those with moderate or non-proliferative, it can worsen their established retinopathy. Question number 3. We have a 64-year-old man with an 8-year history of type 2 diabetes. Is self-referred to discuss newer therapies with you, which has good cardiovascular outcome data. He also has hypertension and dyslipidemia, and he experienced a myocardial infarction 3 years ago. His current medications include metformin, gliflozide, lisinopril, metoprolol, rosuvastatin, and aspirin. So, you examined the patient and you found that his blood pressure is normal, his body mass index is elevated at 33 kg per meter square, and his examination findings are otherwise remarkable. The A1C is elevated at 8.3, creatinine is normal. As you have noticed, Shabab, when you are evaluating patients with diabetes, very important questions to answer: past medical history, the body mass index, the A1C, the creatinine. And this should always be the way you approach patients in your clinics or in your outpatient department or in the medical ward. These are the strong things that you have to always evaluate. He is sent for investigations, electrolytes, liver function, TSH, everything is normal. So you decided to add another agent to control his A1C, which is elevated at 8.3. So which of the following agents would have a lower 3-point major adverse cardiovascular events? And we call these a 3-point MACE, major adverse cardiovascular events, MACE, MACE. So which one of these drugs would you recommend based on the fact that this drug has lowered the 3-point MACE in CVOT trials? A, lixisenatide. B, oral weekly exenatide, once weekly exenatide, C, sitagliptin. D, liraglutide. E, alogliptin. Inshallah, we're going to talk about the details of choosing an anti-diabetic agent in details. But it's very important to know which drugs lower the cardiovascular mortality, which drugs are neutral, and which drugs actually they have worse cardiovascular outcome. Okay, so most of the audience, 50% think that sitagliptin is the correct answer, while the other think that it's liraglutide, which is quite good. So the correct answer is, of course, liraglutide, Victoza, which has been shown to lower the cardiovascular mortality in clinical trials. And as you can see here, we have the EMPA-REG trial about the drug empagliflozin, Jardiance. We have the canagliflozin, which is also an SGLT2 inhibitor. We have the semaglutide, the SUSTAIN, and we have the liraglutide. Where is it? It should be somewhere here. It is not mentioned. But the clear about dapagliflozin and the liraglutide here, the leader trial, sorry, which is beneficial. So we have from the GLP-1, we have the liraglutide and the semaglutide with a positive result. From the SGLT2 inhibitors, we have the empagliflozin and canagliflozin. The declare about dapagliflozin, this is important to remember, it was very good in heart failure prevention, but it did not lower the 3-point MACE. So this is an important thing to keep in mind. What about the other medications that you chose, such as sitagliptin in the TCOS trial, which was neutral, and linagliptin was also neutral in the Carmelina trial. The Savortimi trial, which evaluated the safety of saxagliptin, was actually associated with neutral effect, but it led to increased hospitalization rates for symptomatic heart failure. So, in order to sum up, if the patient has heart failure, please don't use saxagliptin and don't use pioglitazone. This is an important thing to remember. You can use EMPA, CANA, or DAPA, of course, and if the patient is obese, you may prefer to use liraglutide or semaglutide because these have beneficial cardiovascular outcomes. Let's move into the second question. So we have question number 4. 63-year-old woman with a 10-year history of type 2 diabetes presents for follow-up. She has no specific concerns and her medical history is notable for hypertension. Okay, she has dyslipidemia and she has non-proliferative diabetic retinopathy. The other important thing, she has toe amputation and she has congestive heart failure. So this is how things come up in the exam. Patients with multiple problems, you need to choose the best agents for him. She is currently being treated for bladder cancer with intravesical BCG. So this is another point. She's currently taking metformin 500 milligram twice daily, detamir 20 units at night, ramipril 10 milligram, metoprolol 50, spironolactone 25, furosemide 40, atorvastatin 40, and aspirin. So she's basically taking everything there is. Physical examination, the blood pressure is 138/85, and the body mass index is elevated at 36. She has acanthosis nigricans and a 2/6 systolic ejection murmur with weak dorsalis pedis pulses bilaterally. طبعا this 2/6 systolic ejection murmur is which one of you can tell me what is this? Which one of the participants can tell me what is this murmur signifying in the chat? Let's try to test your clinical knowledge. Let me open the chat here. Okay. Patient who has peripheral vascular disease and he has ejection systolic murmur. So some of you suggest this is hypertension. Okay, his blood pressure is borderline. And usually hypertension per se doesn't cause a murmur. It would give you a loud A2, actually. What else? Ejection systolic murmur, 2/6. Okay, good. So now you get it. This is most likely aortic sclerosis. Very good. Now you are thinking. The other important thing here is that there's absence of his left great toe, so he has a previous history of diabetic foot. Lungs are clear. Lungs are clear, it means he hasn't got heart failure, or at least he's dry now. So what would you choose for him? Another important thing before we do that, his A1C is slightly elevated at 8.2, and the GFR is 53. CKD is also a problem in this patient. CBC, electrolyte, liver function, and thyroid are normal. So let's sum up. He's 63. She's 63. She's a woman, and she has type 2 diabetes. She has heart failure, non-proliferative diabetic retinopathy, bladder cancer, toe amputation, peripheral vascular disease, and she's also obese. And you want to, and she has chronic kidney disease. So which one of the following agents would you add next? DAPA, CANA, SAXA, ertugliflozin, or lixisenatide? Choose one of these agents. Of course, this question is quite straightforward, to be honest, but it's very important to remember the adverse effects and the contraindications for each type of anti-diabetic agents. Okay, as you can see, only 6 people think that it's lixisenatide, and of course we have 26 people attending the meeting. Very important thing, lixisenatide is the correct answer. A GLP-1 would be the best choice for this patient. Very important to remember, the best drug to give in a patient with a chronic kidney disease is canagliflozin, Shabab. It is the best drug, but in this patient, although he has heart failure and chronic kidney disease, which would make canagliflozin a great drug for this man, and DAPA as well, because both of them had shown that they have a positive effect on heart failure, and they delay the progression to end-stage renal failure, and they reduce proteinuria, just like ACE inhibitors. But the problem in this patient is that he has peripheral arterial disease, and he has toe amputation. And whenever you are dealing with such patients, it's very risky to start a SGLT2 inhibitor because these drugs, specifically canagliflozin, was associated with an increased risk of amputation. So that's the trick. What about saxagliptin? I just told you earlier that in patients with heart failure, it is not recommended to start saxagliptin. What about urcho? It is not recommended to start urcho in patients with GFR below 60. So remember, the best drug to start in patients with a chronic kidney disease is Cana, and it's probably also the one that you can use with a lower GFR, because usually we don't start DAPA when the GFR is below 45, but we can start Cana in a small dose, 100 milligrams per day, even if the GFR drops up to 30. Below 30, it is not effective, we stop it. But as I emphasized earlier, this patient has toe amputation, she has peripheral vascular disease, and thus starting canagliflozin would increase significantly the risk of further amputations. Lexacenatide is an GLP-1 inhibitor with a positive effect on weight in this patient and would be the best choice in this lady. If you have any questions, Shabab, you can raise a hand at any time and interrupt me, because these questions are tricky and some of you might have some doubts about it. So please don't hesitate to ask me at any time. Question number 5, we have a 45-year-old man who sees you for the management of uncontrolled type 2 diabetes. He has had diabetes for 3 years, so this is important, which makes him a good candidate for oral therapy. It was initially controlled on metformin, but recently his A1C level increased to 8. And he tells you that he's interested in adding SGLT2 to his treatment. So he's asking about the mechanism of action. So you explain to him that SGLT2 inhibitor would do which one of the following? A, block and upregulate SGLT2 in the S3 segment of the proximal renal tubule. B, they lower the renal threshold of glucose from 220 to 180 milligram per deciliter. C, they downregulate the SGLT2 in the S1 segment of the distal renal tubule. D, they lower the renal threshold of glucose excretion from 220 to 100 milligram per deciliter. Simply asking about the mechanism of action of SGLT2. Which one do you think is the correct answer? Okay. So most of you think it blocks the S3 segment. So let's have a look at the correct answer. Of course, the correct answer that it reduces the threshold from 220 to 100, which is quite amazing when you think about it. Let's have a look at the mechanism. So here we have the glucose filtration, and this is the glomerulus, and this is where the SGLT2 work. It's usually work on S1, so this is very important to remember. These are the receptors for glucose here, and once they are blocked, they reduce the glucose reabsorption rate, and they drop the threshold from 220 in diabetics to 100. It doesn't work on the loop of Henle. They don't work on the distal tubule. And it's very important to remember that as the GFR drops down, their effectiveness also drops down. These drugs are amazing add-on to patients with diabetes, with established cardiovascular disease and renal disease, although they are not super effective in lowering the blood glucose levels. The average HbA1c reduction is around 0.5, but they have amazing results for patients with heart failure and patients with chronic kidney disease and patients with established cardiovascular disease. Question number 6, 18-year-old woman is seen for erratic blood sugar values. This question is about brittle diabetes, guys. So she's diagnosed with diabetes 2 years ago, and this is very important when you are dealing with the brittle diabetes. You want to know whether it has been there for like 25 years or 20 years, or just been there over the 1 or 2 years. And I'm going to discuss why later on. The glycemic control has always been adequate, with A1C around 7. However, in the last couple of weeks, she started to notice an unpredictable blood glucose values with recurrent hypoglycemic episodes, with documented values of 45 to 60 that mainly occur after meals, accompanied by symptoms. So she's mainly having a postprandial hypoglycemia. So despite eating more snacks to prevent the hypoglycemia, she's lost 2K in the last 2 weeks. She has no GI complaints or dizziness, and her menses are regular. This is very important to remember. When he mentions the menses, he's telling you that probably her thyroid is okay. She has no GI complaints or dizziness, so he's telling you that she doesn't have autonomic neuropathy. And this is how we ask and how we approach patients with brittle diabetes. We ask them about if they have dizziness, if they have collapse, if they have postural drop, if they have GI symptoms. So this will indicate an autonomic neuropathy and gastroparesis. Her current medications are insulin glargine and Lispro, basically using a basal bolus regime, and the blood pressure is normal, and the body mass index is 22. Physical examinations are remarkable. A1C is 6.7. Cortisol is 20 microgram, which is normal. CBC, electrolytes, creatinine, liver function, everything is normal. So further workup is planned. Which of the following would explain her hypoglycemia? ACTH, 3T4, anti-TTG antibody, 21-hydroxylase antibodies, or gastric scintigraphy for gastroparesis. It should be an easy one. Of course, you will face brittle diabetes in your practice, and they are mainly seen in patients with type 1, and in their teenage years, you quite often see them. And psychological problems are the main issue here, but you need to exclude pathological processes, and these would actually include Addison, celiac, thyroid disorder, autonomic neuropathy, and issues with insulin storage and use, issues with sites of injection, and of course, when you dealt with all of these, then you can go and see, yes, this is mostly psychological, and you have to address that with the patient. This is quite good. So most of you think that it is anti-TTG. One thing I noticed about you guys, so the participation rate is not very exciting. I would be more happy if I see more participation from the audience, because the more mistakes you make, the more you learn. So let's see. So the correct answer in this case is anti-TTG. As you remember, we mentioned that she has no dizziness and the cortisol is normal, so she has no Addison. The menses are normal, and she has her body weight is fine, so she has no thyroid disorders. Even her body weight is a bit on the lower side. Celiac disease should always be excluded in patients with type 1. It should be seen in 5 to 10% of cases, and this is an important cause of hypoglycemia after meals. 21-hydroxylase antibodies are used to screen for Addison disease, but they have no role in this scenario, because the presence of antibody doesn't mean that the patient has established. It only means that he's at risk of developing Addison's. Gastric scintigraphy is a study that we do sometimes, and we have it in Iraq as well, and patients with long-standing history of diabetes with features of autonomic neuropathy, to document that the cause of brittle diabetes is actually gastroparesis. That was a very important question, Shabab. Brittle diabetes is a very difficult problem to deal with, and you need to establish and to know how to approach these patients in your daily life. Let's move on to question number 7. So we have a 31-year-old woman with 2-year history of type 1 diabetes who's asking you for advice on how to reduce the future risk of heart disease. Her 53-year-old father, who also had type 1 diabetes, had a myocardial infarction, so she's a bit worried. The patient is on multiple daily insulin injection therapy, but she doesn't count the carbs and she makes insulin adjustments before meals. So she's using corrective insulin dosing. As you know شباب شوي نطلع عن السؤال. نحن اكو طريقتين بالتايب 1. اكو كارب كاونتينج، يعني المريض يحسب يتعلم انه يحسب الكربوهيدرات بالوجبه ويحسب الانسولين حسب الكربوهيدرات وبها معادلات. ما طبيت بالهم ما ادوخكم بها. This is our job. واكو الكوركتيف دوزنج اللي هو ده تصير بهاي الكيس لازم تعرفوه. يعني عاده بالتايب 1 it is 50 for each 50 above 150. بالتايب 2 it is usually 2 units for each 50 above 150, and of course this is variable. فهاي مهمة انه تعرفوها خاصة بالhospitalized patients. هسه نحكي عليها اذا صار وقت اليوم. Let's go back to our case. So she has experienced several episodes of mild hypoglycemia in the last 6 months and 1 severe episode that occurred overnight. So this is important. So she had an overnight episode of hypoglycemia. She didn't bring her glucose meter or log to the visit, and the blood pressure is normal and the pulse rate is normal. HbA1c is elevated at 8.6. The LDL is 98. The HDL is 64, and everything else is normal. And she asked you about how to lower her cardiovascular risk. Remember, Shabab, she's asking about how to lower her cardiovascular risk, and she's only 31. And she has 2-year history of diabetes. I'm just emphasizing the important points for you. And she has an elevated A1C, and the LDL is 98. HDL is high. What would you like to tell her that would be most useful in reducing cardiovascular disease risk? Most useful in this patient with type 1 diabetes. Lowering the A1C to a level below 7. So you just put her on a strict regime. You start treatment with a statin. You start treatment with an ACE inhibitor. Or you reduce the long-acting insulin by 20% to avoid hypoglycemia, because hypoglycemia is a very important precipitant of cardiovascular disease. You need to choose only one. Of course, guys, you know that we have 2 big trials that evaluated the effectiveness of lowering A1C below 7 in reducing micro and macrovascular diseases. We have the DCCT trial, which was conducted in the UK, and it was published in 1993, as I believe. And we have the UKPDS. Sorry, the UKPDS was in the UK, and the DCCT was in the US. DCCT dealt with patients who have type 1 diabetes, while UKPDS dealt with patients who have type 2 diabetes. And from these 2 big trials, we came up with the conclusion, the early conclusion, that in order to reduce the microvascular complications, we need to lower the HbA1c. But in order to reduce the macrovascular complications, we need to lower the blood pressure, treat with statin, prevent proteinuria. But this has changed actually over the last few years, as I'm going to demonstrate. So here, most of you think that you need to actually lower the A1C, which is quite correct. I congratulate you on this. So let's see, why is that? So this is the DCCT. Of course, all of you should know the DCCT, because if any questions about any trials comes up in the exam, it is about the DCCT. And this trial had shown that it reduces retinopathy, neuropathy, and nephropathy, and microalbuminuria. مرات سؤال يجي بالامتحان انه which one of these are mostly prevented. فعلى مود تحفظوها شباب، وانا دائما اقولهم للمقيمين شباب من جوا لي فوق، من جوا لي فوق، من جوا الرجل نيوروباثي، بعدين عندنا النفروباثي شويه اعلى، وبعدين عندنا الريتينوباثي. فالريتينوباثي اعلى نسبه ريدكشن فور بريفنشن، وراها تجي النفروباثي، وراها تجي النيوروباثي. هاي خلوها ببالكم لان السؤال يجي بالامتحان. These were the initial data. What they did is that, as you are going to see here, let's see this table. So this is table in front of you. So here we have the cumulative risk of any predefined cardiovascular outcome. And here we have the risk of myocardial infarction and stroke. So let's look at this one first. So here we have the two groups, the intensive treatment group, which had an A1C below 7, and here we have the conventional treatment group. And when they followed these patients many years, so early follow-up up to 7 years, as you can see here, both lines were a bit similar. So when they published their data, they said that there was no difference if you lower the A1C below 7. There will be no significant difference in the cardiovascular disease. But as they followed the patient later on, because this patient got older, and they noticed that those who had conventional treatment had significantly higher risk of cardiovascular disease compared to the intensive treatment group, as you can see in this slide. And there was a 57 relative risk reduction in the intensive treatment group compared to the conventional treatment group. This is the first thing. The other interesting part regarding the EDIC trial, which is a continuation of the DCCT. So those who had intensive treatment group, they loosened up their control a little bit, and they compared them to the conventional treatment group. And they found a very important data. They found that those who had intensive therapy during the first 5 years of their diabetes had a significantly lower cardiovascular risk compared to those who had the later good control. So the first 5 years of diabetes are very important to determine the risk of cardiovascular disease in the future. And this is what we call the legacy effect. If you have a good control early on, this will show up later on in your life, even if you have loosened your control later on. So this is a very important part to remember and understand about the diabetes trials. Question number 8. A 24-year-old with type 1 diabetes is diagnosed 4 months ago, and now he's presented with recurrent hypoglycemia. So this question is about honeymoon period, as you are all aware. He's now on basal insulin with a rate of 0.35 unit per K, and he's also using short-acting insulin. The weight is 55, and the A1C is 6.3, so he's in remission, down from 12.4, which was at the diagnosis. She performs self-monitoring, and he's telling you that she's having recurrent hypoglycemias, and she's also having fasting hypoglycemia in the mid-50s, once or twice a week. What would you do for this patient? Reduce the basal insulin by 10 to 20%, reduce all insulin by 10 to 20%, reduce premeal insulin by 10 to 20%, or tell her to eat more and increase the carbohydrate intake to at least 50 grams with each meal. What do you think is the correct answer in this case? طبعا honeymoon period is commonly seen in type 1. It is not seen in type 2. This is important to remember. 5% of patients with type 1 can have honeymoon period. And this usually doesn't extend beyond 1 year. So this is important to remember. طبعا هي هاي الفترة اللي يستغلها الدجالين والعشابين والعطارين انهم يضحكون على الناس. It's very important to explain to patients with type 1 beforehand that they may have this part. Most of you think that you should use all type of insulin, and this is quite correct. In this patient, you need to reduce all type of insulin. And if you have still recurrent attacks of hypos, you would stop and omit the rapid acting. But it's very important to remember that you need to keep him on some basal insulin. You should not stop all types of insulin, because giving them basal insulin would preserve their beta cells for as long as possible, and preserving this 5% of beta cells or 10% of beta cells of whatsoever is very, very important in preventing the development of brittle diabetes later on, because these 5 or 10%, they can help you a lot in curbing the excursions of hyperglycemias that can happen every now and then. So question number 9, we have a 34-year-old man with type 1 diabetes who is in the clinic waiting, but he develops hypoglycemia with a 40 milligram per deciliter, and he can barely speak. So after recovery, he's telling you that he's been using his CGM, continuous glucose sensor, and he's having recurrent hypoglycemias 5 to 6 times over the last few days, and they are usually over the range of 40 to 50 without any warning symptoms. Without any warning symptoms. So he's having what? Hypoglycemia unawareness. Okay. What is his history? He has 16-year history of diabetes. هاي وحدة. He also is aiming for tight control, and his A1C is 5.9 because he's afraid of developing long-term complications. And he is using multiple daily insulins, يعني basal bolus. So which one of the following is the most important next step? You temporarily relax his tight glucose targets. B, you instruct him to always carry a glucagon emergency kit. C, you begin using an insulin pump for insulin administration rather than MDI. D, you attend a diabetes education class focusing on hypoglycemia avoidance. يعني you relax the insulin, يعني you reduce, or you give him an emergency kit, or you shift him from MDI to a pump, or you educate him. Of course, all of these are possible answers for this question. But which one of them is the most appropriate next step? Of course, all of them are very legal choices in this case. Okay, I'm quite happy with the performance of you guys so far. You're doing great. So let's see. Okay, so most of you think that you should relax, but many of you think that they should do something else. The first and most important step in managing hypoglycemia unawareness is to relax the tight glucose control. And why this happens? Of course, this happens because of the depletion of glucagon and the attenuated epinephrine secretion. And this is actually more difficult to control in patients with long-term diabetes. This also might be accompanied by inability to reduce the circulating insulin. And we basically call this an autonomic failure. What is the mainstay of treatment? The mainstay of treatment is to avoid hypoglycemia. You can even push the A1C target for 8 or 7.5. If the patient doesn't have severe advanced autonomic neuropathy, they usually recover within a couple of weeks. So you relax the targets for, you put them as a fasting target of 150 to 200 and a postprandial 200, 250 or 150 to 250 for a couple of weeks, 1 or 2 weeks, and then they will start to recover their autonomic function, and they will be more aware of hypoglycemias this time. But some patients actually, they have severe autonomic failure and they will not recover. And in these patients, you have to relax your A1C target, and you should aim for an A1C of 8 actually, especially if the patient is above 60, he has cardiovascular disease, because development of hypoglycemia in these patients is quite worrisome and associated with the worst long-term outcome. And this had been shown actually and proven in the trials. So the last question for the first part of today is about a 33-year-old woman who presents for the management of type 2 diabetes. This is a very important question because it deals with the up-titration of therapy. So 3 months ago, the A1C was 8.9, and she has long-term obesity with 34 K per meter square. She enrolled in a hospital-based diet, and she was able actually to lose 2.3 K. She's been engaged in lifestyle modification, and she's on metformin monotherapy of 1,500 for the last 3 months, and her A1C has plateaued at 7.8. The fasting glucose was 146. Which one of these options is the best thing to do for this lady? Should you stop metformin and begin insulin, large in 10 units at bedtime? Should you add sitagliptin 100 milligram to the metformin? Should you increase metformin to 2,000 because she still hasn't reached her optimum dosing? Should you stop metformin and begin sitagliptin 100 milligram daily? Which one of the following would you choose? Remember, Shabab, her A1C now is 7.8 after 1,500 metformin. And she is obese. And she has recently developed diabetes. Okay, 10 seconds, Shabab. Good. So the majority thinks that you should add sitagliptin, which is the correct answer. What about the other options? Increasing metformin to 2,000 would only be able to reduce the A1C at around 0.3 to 0.4. So the A1C will still be higher than 7, which is the target in this lady who has recently diagnosed type 2 diabetes. Adding sitagliptin is the best option here because it can be associated with lowering of A1C of up to 0.7 or 0.8, so it will bring it to 7 or just below 7. Substituting is, of course, not a good option. And adding insulin, although it would reduce the A1C, it will be associated with increased risk of weight gain, which is not favorable in this patient. So let's spend some time here, Shabab. This is the newest recommendations of the ADA from 2020, and I recommend that each and every one of you has a look on this chart and on the book they published. It's free, it's present online. The most important things you need to know is that for each patient with diabetes, there is a specific therapy that is useful for him. And the most important question to answer, the first line here, Shabab, the first line is always metformin and lifestyle changes. Once you do that, you have to answer this question. Is my patient having problems with his heart, with his kidneys? So does he have an established ASCVD, chronic kidney disease, or heart failure? because this will determine the next medication you have to add, regardless of his initial A1C or your target. And as you might know that for each patient, we have specific target. So let's say, for instance, the target is 7, you started metformin, and the A1C came like 6.5. So you reached your target, but your patient has a history of myocardial infarction. Okay, would you stop here or would you add something else? According to the news guidelines, because he has heart failure, he should be started on an SGLT2. So this is an important update. Okay, in the previous recommendations, they said you add if the A1C hasn't reached target. Now they say if he has ASCVD, CKD, or heart failure, you need to consider these drugs. Of course, moving this way actually means that the management of diabetes is moving away from HbA1c, or what we call a glucocentricity, and it's moving towards more controlling the comorbidities and treating the patient as a whole. So let's see what they are recommending here. So if my patient has heart failure or chronic kidney disease, you need to choose an SGLT2, as I explained earlier, unless there is contraindication. If the GFR is below 45, you would go for CANA, otherwise you can choose anyone. If the patient has predominantly heart failure, of course, DAPA is the preferable agent. If the patient has albuminuria and chronic kidney disease, CANA is the preferable, but any one of them is good enough, so use any one of them. If SGLT2 are contraindicated, then you have to use the GLP-1, such as liraglutide. If you don't get the A1C controlled, you add a GLP-1. If you don't reach that, then you go for other agents like insulin, DPP-4, sulfonylurea, and things like that. What if my patient has ASCVD predominance? For instance, he has history of myocardial infarction but doesn't have heart failure. Of course, here they specify like age more than 55, coronary artery or carotid or peripheral arterial disease, or extremity stenosis more than 50%, or LVH, shabab, LVH, here they mention it, you should use GLP-1, like liraglutide or semaglutide or lexasenatide. If the patient is intolerable, cannot afford, you give the SGLT2 with a proven cardiovascular evident benefit if the GFR is adequate. If you reach the target, that's fine. If you don't reach the target, then you think about adding another agent. If the patient is using GLP-1, you add SGLT2. If he's using only SGLT2, you add GLP-1, as long as they can tolerate it. Otherwise, you can use DPP-4. Of course, remember, when you use DPP-4, like let's say saxagliptin, of course, the patient should not be on heart failure, or sitagliptin, or vildagliptin, the patient should not be using a GLP-1 because they share a similar mechanism of action. You can choose basal insulin with cardiovascular safety like Glargine or Detamir, or the newer types of insulin. Thiazidinones are good options, but the patient should not be suffering from heart failure or obesity. Sulfonylurea can also be used. So this is how you should approach your cases in your real life and in your exam. Otherwise, if the patient has risk of hypoglycemia, then you should avoid the sulfonylurea. Remember this, and you would focus on GLP-1, SGLT2, TZD, and DPP-4. If the patient should lose weight, as we have seen earlier, then you should choose either GLP-1 or SGLT2. And of course, GLP-1 is the preferable agent here. And if you want to combine them, this is even better if the A1C is above target. But if the A1C is not above target, you should not combine them for the only reaching a weight loss target. يعني مو من الصحيح انه انت تسوي combination of GLP-1, let's say liraglutide, and SGLT2, like let's say ganaplaclozin, just to get a lower weight if the A1C is above target, because you are risking hypoglycemia here. So you need to have an A1C above target, then you can combine them together. If the cost is an issue, then you can use the sulfonylurea initially, as we sometimes do in many of our patients that we see in the outpatient department, for instance. because these patients, they cannot afford the newer medications which are not supported by the government, and they have to be bought by out of the pocket. So in these patients, you are justified to start metformin and sulfonylurea if the patient cannot afford. So by this, Shabab, I complete my first part, and I welcome any questions before I give you a short break of 5 minutes, and then we return to discuss the issue of lipids and diabetes. I see you have a question here. Why not escalating metformin to 2000 before adding combination? Very good question, Dr. Muaz. I think I tackled this matter. Up titrating metformin from 1500 to 2000 is a good option, of course, but it will not get you the A1C that you want in this patient. It will just get the A1C from 7.8 to 7.3 or 7.4, which is still above the target. But adding sitagliptin will bring down the A1C to around 7, which is the usual target in newly diagnosed patients. Of course, you can always increase to 2000 and then you add sitagliptin, but it will just mean that you delay the proper treatment for like another 3 months. And that's why in the newer guidelines, if the A1C is 1 above the target, so in this patient it's 8, because her target is 7, you should consider starting combination therapy with dual agent from the start, not monotherapy with metformin. I hope I answered your question, Dr. Ma'iz. If you have any further questions, I welcome them in the chat, or if anyone wants to unmute himself, I think he can. Okay, we will have a 5 minutes break and then we would return, Shabab.
ان شاء الله دكتور.
Uh, we have another question um, before we resume. So Mr. Saif is asking, what is the role of anti-GAD65 in differentiating type 1 from type 2 in border age? Of course, we have some cases in which they have, let's say they present in their 30s or in their 20s, and you can tell, you cannot tell whether this is clearly type 1 or type 2. And here, the clinical representation is very important. So if the patient presents with ketosis or with significant osmotic symptoms and severe weight loss, this is most likely to be type 1. If the patient has a family history, then this is also very important, because presence of positive family history can be more indicative of type 2 or MODY. If the patient has a negative history, then this is maybe type 1. Other important findings, the A1C, if the A1C is above 10, then you don't need to worry about this. You just give them insulin, and then you think about reevaluating them later on. But in cases when you cannot tell, you can send for anti-GAD65, which is a very useful autoantibody. It is present in 70% of those with type 1, but the 70% is eventually, they are not all positive at the diagnosis. So you need to appreciate that. C-peptide might be useful in some cases, but in those with high A1C and those with severe hyperglycemia, you would get it low even if you are dealing with type 2. So a normal C-peptide may also be encountered in patients with type 1. So it is not very useful, but if you find it very low, then you can tell that this is mainly type 1. Other autoantibodies are also useful, like zinc transporter 8 and anti-islet cell antibody, as you mentioned, but unfortunately we don't have them here. I hope I answered your question, because there is no perfect answer. You have to get it all together. Okay, so let's start with the second part of our meeting today. So the second part is about obesity and lipids, which is a very exciting subject to my heart, I have to be honest. And I've prepared some material to cover both obesity and diabetes. So let's start with a few questions about obesity, because this is coming a lot in the exam. Just having some technical problems, sorry. Bear with me a little bit. Yes. Should be right. Okay. So the first question is about obesity and about the complications of bariatric surgery. And now we are seeing this more and more in real life and in the exam as well. So the first case is a 36-year-old woman with a peak BMI in her life of 46. And now she had laparoscopic gastric bypass 8 weeks ago. She initially did well, but over the last 3 weeks, she began experiencing vomiting. Over the last 5 days, she's been vomiting almost everything she eats. Over the last 2 days, her husband has noted that she's becoming increasingly confused, dysarthric, and unsteady in her feet. I hope the presentation is clear to you guys. So in the last couple of days, she's getting confused, ataxic, and dysarthric. You examined her and you noticed that she's clearly confused. She's got nystagmus and ataxia, and she has reduced sensation in her lower extremities, and she has a right third cranial nerve palsy. So which one of the following is the most likely deficiency? B12, folate, thiamine, or folate is repeated twice. So you have to omit this folate, and instead of folate, you add zinc, Shabab. This is a mistake. This is zinc. Because of the limitation of Zoom, the second question you just answer randomly, Shabab. Okay, it's an easy question, but it's an important one, and we will use it to review the early and late complications of bariatric surgery and the important nutritional deficiencies that you can encounter after bariatric surgery. In general, guys, we have early and late. Early is for the vitamins that you lose them rapidly, and late for the vitamins that need a lot of time, which have good storage, like in the liver, like B12, and as I'm going to discuss later in detail. Okay, let's end the poll. Okay, so the majority thinks it's thiamine, which is quite correct. So the clinical representation, even if you don't know, the clinical representation of B1 deficiency is quite evident in this case. Here we see the table that tells you how to approach these cases. Pay good attention here. B12 usually takes 2 or 3 years, sometimes even longer for it to get depleted from the liver. So the clinical representation with glossitis, peripheral neuropathy, and subacute combined degeneration with megaloblastic anemia usually takes quite some time, and you would not see it in 8 weeks after the surgery. Folate can present early, but usually late, and it's associated with malabsorption. B1 thiamine is commonly seen early during the course of illness, as you can see in red, شباب. In red, اللي باللون الأحمر هي early presentation. الباللون البنفسجي هي 6 to 12 months. واللي باللون الأسود usually 1 to 2 years. يعني نقدر نقول البنفسجي هي intermediate والأسود هو late. So B12 usually intermediate or late. Folate is late. And thiamine is early. Of course, the classical representation is described in the case, and the treatment is usually with IV thiamine. You should avoid giving glucose because it can worsen her condition. Zinc, usually the patient presents with skin rash and diarrhea, and this is due to malabsorption, of course. One other point to remember, all of these vitamin A might also be encountered, and these patients, they present with night blindness and poor wound healing. Of course, there is a specific follow-up chart for these patients with timings to send for each investigations, and unfortunately, many of these patients are being followed by the surgeons who don't pay good attention to these details, and they should be followed by the dietitian and the endocrinologist after they do the surgery. B1, as we described in the case. B12, you know all the findings. Zinc, we discussed. One other thing, guys, these patients may have increased requirement of vitamin D because there's malabsorption, and they may have increased requirement for thyroxine if they are hypothyroid. Because of the diversion of the pathway and the hypochlorhydria that can happen after surgery. A 38-year-old man with a body mass index of 39 asked about weight loss medications. Now we come to a very interesting subject for internists, is the drugs, which drugs you should use. And he is frustrated with his weight, and he wants the most effective medication. He tells you, I want the best medication that can lower my weight. And I'm not concerned about the side effects. Whatever happens to me, I don't care. Just give me the best drug. So which one of the following would you give him? Locazerine 10 milligram twice daily, phentermine topiramate, which is called Xemia, 15 milligram, 92 milligram daily. This is a combination of phentermine and extended release topiramate. C, you give him phentermine alone. D, you give him the liraglutide. E, you suggest orlistat 120 milligram 3 times daily with meals. So which one of these medications has the greatest impact on weight, regardless of the side effect profile? Most of these medications we don't have. We have liraglutide, orlistat, topiramate, we have it. Phenantramine we don't have, but we have an alternative with the same mechanism of action. It's called tinoate. The scientific name is diethylpropion. It is FDA approved, and it works just like phenantramine. So sometimes what we do as endocrinologists, we combine both of them. We combine the topiramate with the tinoate to get this phenantramine topiramate equivalent, which is not available here. Let's see the correct answer, Shabab. So the correct answer in this case is to give him Dexemia, which is the phenantramine topiramate, which is surprisingly more effective even than liraglutide 3 milligram per day. Because as you can see in this table, you can get 6 to 9% of weight loss and up to 10% at 2 years with good safety profile with phenantramine topiramate compared to 3 or 5 to 7% with liraglutide with an average of 6% at 3 years. So you see here we have 10.5% from the baseline. Here we have 6%. Phenantramine topiramate is the most effective weight loss medication that we have so far, apart from semaglutide, which is planned to be put in the market in the couple 6 months or 1 year in Iraq. Orlistat 3 to 5%. The Belvic or the lorcaserin has been withdrawn from the market, I think 1 year ago, due to increased cardiovascular events. The naltrexone bupropion contrave is also a good option, but it can give you only 4 to 5%. And it's a very good option in patients with depression, while the combination of phenantramine and topiramate is just great in patients with migraine. But you need to take good care when you are prescribing it for females with the childbearing age, because topiramate is teratogenic, and these patients should be covered with oral contraceptive pills or some other protection. What are the mechanism of action for each of these drugs? Lorcaserin, I will not talk about it because it's withdrawn, but it's a selective 5-HT2C receptor antagonist. Phenantramine is very, very nice combination. This is an appetite suppressant and it's a pathomimetic regarding phenantramine, while topiramate works on the GABA receptors. One important concern is that the phenantramine may slightly elevate the blood pressure, but this is not a contraindication, such as well as the arrhythmias. But we have used them a lot, and the presence of hypertension is not a contraindication for this medication. Orlistat, all of you know, it works on the gut. One of the major adverse effects that you can see is bloating and diarrhea. But an important scenario to keep in mind, if this drug has been used for many years, patients can present with nephrocalcinosis and renal failure. So this is an important long-term adverse effect of orlistat due to hyperoxaluria. Liraglutide or the Saxenda or the Victoza, it is the same actually. Victoza and Saxenda are the same drug. The only difference is in the container. When you are using it for obesity, you go for 3 milligram, while the liraglutide, when you're using it for diabetes, you don't exceed the 1.8 milligram per day. These both are appetite suppressants. They carry some risk of pancreatitis and medullary thyroid cancer, and as mentioned in the diabetes questions, they can worsen the retinopathy, especially macular edema. One important other concern is that if patients with advanced gastroparesis, they can worsen it, and patients may present with vomiting. And finally, there's increased risk of gallbladder disease, but patients without cholecystitis are not contraindicated to receive this medication. This is the cautions that I just discussed. You can check them later on. All of them are relatively safe medications. They can be used for long term, but you need to choose them wisely in your patients. If you have any questions about the medication, Shabab, I will welcome these because most of you would want to use them. Okay, you can either write them in the chat or you can write them in the question and answer. We move on to question number 3. We have a 51-year-old woman who underwent placement of an adjustable gastric band 4 months ago. If you have noticed, Shabab, I have chosen scenarios that I have seen in my practice over the last couple of years. So these are very commonly seen in your practice as well. She has been losing weight gradually and she's having no problems. So everything was going fine. And she's having this band for 4 months. But last night, she was at a restaurant and she developed severe abdominal pain and began vomiting all at once. She's unable to even keep water down, and she calls the practice for advice. What do you think has happened to this lady? Is it an stomatic ulcer causing obstruction? Is it band erosion? Is it food impaction? Or is it leak? Or is it band slippage? Which one do you think has happened to this lady? Of course, band procedures are commonly used because they are non-invasive and the surgery is very low risk and they are put endoscopically. So they are mainly used as a bridge for patients with high risk of GA, such as those with a body mass index of more than 40. And they are quite effective in reducing weight for up to 10%. Which is very, very good for anesthesia in these patients. If you get 5% in a patient who has a BMI more than 4%, more than 40, this will significantly reduce the perioperative complications, especially the pulmonary complications and the recovery time. Of course, the important adverse effect of these bands is erosion, slippage, and of course the need for frequent adjustments. Good. So most of the audience think it is food impaction. I'm quite happy with that. So let's discuss the side effects or the complications of each type of bariatric surgery. Let's start with our case. So food impaction here, usually it is acute presentation as we had it in our case. Patients present with acute onset of nausea, vomiting, and abdominal pain. This is because the band is actually too tight and some parts of food get impacted. And usually you just need to release the band a little bit and everything goes back to normal. Band erosion, these patients usually present with gradual unexplained abdominal pain. They start gaining weight and eventually they may even erode into the skin, and patients present with infection and even sometimes perforation. But this is very importantly to remember, this develops gradually and insidiously over the first year, but it can take up to 5 years. What about the other complications like band slippage? Usually this is later, and this is due to the migration of the band into the esophagus, and this usually due to failure of stitches or staples. So it just slips and goes up and causes reflux, nausea, and vomiting and abdominal pain. One important adverse effect of anastomotic leak, this is seen in patients who underwent gastric bypass surgery, or even sometimes after sleeve surgery. And this is very, very important to recognize early, because the initial presentation can only be tachycardia and tachypnea. And this scenario has come up in the final exam, I think 1 or 2 years ago. So if the patient has tachycardia after surgery, after bariatric surgery, the most important thing to consider is anastomotic leakage, and you have to send the patient back into the operation room. Other features for these patients is that they usually suffer from shoulder pain due to the irritation of the diaphragm, just like cholecystitis, but it comes up on the left side. And this is due to ischemia of the anastenosis. Some other presentation is anastomotic ulcer. and of course, this is not seen in patients with lap binding, laparoscopic binding. This is seen in patients with gastric bypass. And this actually is quite serious, but it presents later on. And it's just like the ulcer pain, it presents with pain and bleeding, and sometimes even obstruction due to fibrosis, edema, and gastric outlet obstruction or outlet obstruction. So in this slide, we have reviewed the most important post-surgical complications that you can meet in real life and in the exam. Let's move into the fourth scenario for today. So we have a 39-year-old man who comes to see you and helping to treat his elevated cholesterol. Yes, so now we move into the lipids. His father had died of MI at the age of 29, and his brother had angina at 32. And he had intermittent chest pain that is consistent with angina, but he hadn't had any diagnostic testing. And he is currently taking atorvastatin 80 milligram daily. You check his LDL and it comes back at 245. The fast physical examination, he has thickened Achilles tendons and nodules on the extensor tendons of his hands. So simply you are dealing with a case of FH or familial hypercholesterolemia. So what do you think you should add for this man? A patient who has FH, he has features of angina and a positive family history of premature coronary artery disease, and his LDL is above the target. You add ezetimibe, you add fenofibrate, evolocumab, niacin, or you change to rosuvastatin 40 milligram. Remember, he is using atorvastatin 80 milligram. What do you think is the best next option? Okay, so unfortunately, the majority thinks that you should add ezetimibe. Only 2 persons here chose correctly, and they added evolocumab. Evolocumab is the correct answer in this case. So why is that, Shabbat? The 2 good options in this case is ezetimibe and evolocumab. And if you know that adding ezetimibe to a statin would give you an extra 25% reduction from in the lipid profile, LDL specifically. So if his LDL now, as you can see, is around 245, a 25% would bring it back to like 200 or 190. So he's still way beyond the target, while adding evolocumab, although it is expensive and injectable therapy, it would bring it back to 50% down. So it will be like 120, which is way better than ezetimibe here. So evolocumab is a PCSK9 inhibitor, and this has been shown to significantly reduce the LDL for another 50 to 60%, with a cardiovascular reduction of 15 to 25%. And this is quite amazing in patients with FH. Improved trial has suggested that adding a statin would be beneficial to ezetimibe, and it would result in 6%. But as I explained, it will not achieve the reduction that you would actually aim for. Those of you who chose fenofibrate, this is completely wrong, because fenofibrate is a drug that works in triglycerides, and it will not be effective in patients with FH. Niacin, although it can reduce, it is not effective, and it wouldn't increase it would even increase the stroke risk, and it would not reduce the cardiovascular risk. And changing 80 to 40 rosuvastatin is not useful. Even Shabab, even if it was on 40 milligram atorvastatin, changing it to 80 milligram, it will only bring like, I think, 6% extra reduction. So 40 to 80, or even rosuvastatin. Of course, rosuvastatin 40 is equivalent to atorvastatin 80, but I mean, if you get a question when you get to increase the rosuvastatin from 20 to 40 or the atorvastatin from 40 to 80, remember that it would give you like 6% extra reduction. And that's why they are both grouped into the same intensity. So 40 to 80 atorvastatin is high intensity statin, and 20 to 40 rosuvastatin is also a high intensity statin. Okay. Question number 5.
العفو دكتور عراز، اكو سؤال الكيو اند اي.
Let me check.
دكتور محمد.
Dr. Muhammad Abed, what do you prefer from those drugs to lose weight and its availability? I think I addressed this question during my discussion, but okay, I will repeat that because this is very important. So what we have in the market is the following. We have liraglutide, Saxenda, and the Victoza. We have the tenomate, which is the diethylpropion equivalent to phenetramine, and we have the topiramate, but the topiramate that we have is immediate release, not the extended release. So off-label, we are using a combination of diethylpropion with topiramate. This is off-label. This combination is not available, and it has not been studied, but this is being used anecdotally based on the data from topiramate phenetramine combination. But unfortunately, this is not supported by evidence. But this is what we have. Another drug that we have is the orlistat, and the orlistat is present for quite some time now. And of course, it is not very effective. It's like 3 to 5%, and compliance is an issue. And combining more than one type of medication is not recommended. So usually we don't combine, let's say, topiramate with liraglutide for the sake of weight loss alone, but maybe combined, for instance, for if the patient has migraine or another indication like peripheral neuropathy maybe. So this is what we have here. It is supposed that semaglutide will be available in the market in the next year. And this is a great news because it can be used once weekly. Another drug that I see being used recently for weight loss is Trulicity, which is used once weekly for diabetes with 0.75 and 1.5 milligram per week. The doses for obesity is much, much higher, reaching up to 3 or even 4.5 milligram per week. But this is still not widely available or proven. But this is what we have. I hope I answered your question, Dr. Muhammad. And if you have anything you'd like to elaborate, please write it down in the chat. Going back to our cases, the fifth scenario is about statin-induced hepatitis. So you are evaluating a 57-year-old man who has type 2 diabetes and an American Heart Association 10-year risk of 15%. ASCVD risk 15. He has history of Hep C and mild chronic elevation of transaminases, which is less than 2 times the upper limit of normal. He's heard that statins could cause liver injury, and he's very concerned about it. But his LDL is 156 and his TG is 220. So he has type 2 diabetes, his LDL is elevated, and he has typical diabetic dyslipidemia with TG elevated and LDL 156. And he's asking about statin, and he's a bit afraid of it. Do you have any other alternative, and what would you like to give him for his treatment? Should you give him statin? Should you recommend diet alone and complete his hepatitis treatment course and then restart statin? Should you give him a fibrate? Should you give him an ezetimibe, which is also effective in lowering his LDL, or should you give niacin? So this question is about using statins in patients with liver disease. Okay, good. So we have good percentage here. So statin is the best drug here. Important points about using statins in chronic liver disease. If the liver functions are below 3 times the upper limit of normal, as shown by Greece study, it is completely safe to use it. And there is no evidence that statins cause fulminant hepatic failure. Important facts to be remembered that hepatitis C, NAFLD, and NASH are all of these patients are good candidates for statin, especially that fatty liver is an independent risk factor for cardiovascular disease. And still, cardiovascular disease is the commonest cause of death in these patients. Well, what about the other options given in this scenario? Diet alone will not be effective. Fibrates is an anti-TG med. Ezetimibe is not recommended to be used alone. Remember, guys, using ezetimibe alone has not been shown to reduce the cardiovascular risk, even if it lowers the LDL. Niacin is not recommended despite its effectiveness in raising the HDL and lowering the LDL because of the increased risk of stroke and because of no evidence has been documented in the AIM-HIGH trial that niacin would lower the cardiovascular risk. Question number 6. So we have a 30-year-old woman without diabetes who presents with acute pancreatitis, and her TG level is 5,000. So this is TG-induced pancreatitis. And she's admitted to the hospital, and she's been given treatment with supportive care as recommended per all patients of pancreatitis. So what additional therapy could be used as a method to reduce the liver production of TG in this patient, or what are the lines of therapy of TG-induced pancreatitis that you are aware of? A, insulin and glucose. B, fenofibrate. C, heparin. D, tamoxifen. E, metformin. I don't know if I have seen such cases, but I have seen one actually when I was a resident. And at the time, I didn't know that I need to give the correct answer. So I think this is very interesting. Nice. Most of you chose fenofibrate, which is the wrong answer, of course. Please focus at the question, guys. So the question is telling you which of the following methods reduce the liver production of TG. Fenofibrate works on lipoprotein lipase, and it increases the uptake in the peripheral tissue. So it is not the correct answer. And it is not actually part of the treatment for TG pancreatitis. The mainstay of treatment of TG-induced pancreatitis is IV fluids, milk by mouth, insulin and glucose drip, because insulin stimulates hepatic lipoprotein lipase, which breaks down and clears TG, and it inhibits the hormone-sensitive lipase and adipose TG lipase, and it inhibits the release of TG from the fat tissue. While glucose is added just to prevent the hypoglycemia. Fenofibrate is used in long term. It is not effective acutely. Heparin, interestingly, is one of the lines of treatment, but it's actually, it works on the lipoprotein lipase, which is present in the arterial walls, resulting in a breakdown of TG. But of course, there is a risk of pancreatic hemorrhage in this case. But it is mentioned as one of the lines to treat TG-induced pancreatitis. Estrogen, of course, they elevate the TG and would get things worse, of course. Metformin has no role. Plasmapheresis would actually lower the triglycerides, but it's usually not needed except in very extreme cases. So I hope you learned how to treat TG-induced pancreatitis. You give them fluids, you null by mouth, and you give them insulin and glucose water. That's it. If you want, you can give them heparin, but you have to be careful. Question number 7. You are referred a 38-year-old man with a 12-year history of coronary artery disease and multiple hospitalizations for coronary artery stent placement. Very high-risk patient. The patient has a very strong family history of heart disease. His father, his 2 paternal uncles are both dead by the age of 50. And he's currently taking atorvastatin 80 milligram. You check his lipid profile, his total cholesterol is 210, the LDL cholesterol is 150, the HDL is 40, the TG is 100. Of course, the LDL cholesterol is sky high as the target in this patient is less than 55. The question here, on physical examination, you should look for which of the following findings: lipemia retinalis, corneal arcus, eruptive xanthoma, palmar xanthoma, or erythropathy. So this question is about correlating the clinical findings with the type of hyperlipidemia. Each of these findings mentioned in the options here are correlating with a specific type of hyperlipidemia. What do you think is the correct answer? Should be an easy one, guys.
دكتور متساوية النتائج.
اي ما completely equal يعني balanced, and this is very unfortunate, of course. The correct answer is corneal arcus, of course. Lipemia retinalis is seen as in hyperchylomicronemia, which is a type of combined of TG elevation. Eruptive xanthoma is, of course, seen in hypertriglyceridemia. Palmar xanthomas are seen in this beta lipoproteinemia or type 3 familial hyperlipidemia. You should know these things, guys. As you can see in this picture, this is the lipemia retinalis in picture A, and this is usually seen in patients with severe hyper TG, more than 3 gram or 3000 milligram per deciliter. And you can see that all the retinal vessels seen here are white in color. This is the corneal arcus. Of course, this is the one that has been shown here in the picture. This is a senile one. Usually the one that we see in patients with FH is classically seen an asymmetrical pattern. So this is, you can see this is quite symmetrical. C shows eruptive xanthoma, as you can see, like fleshy skin protrusions, which are seen mainly over the thighs and over the knees. And this is the palmar xanthomas, which are seen in this beta lipoproteinemia, and they usually indicate high total cholesterol and high TG. So they are elevated in patients with combined hyperlipidemia. Of course, erythropathy is not a sign of hyperlipidemia. Question number 8, and it's about statin myalgia. Those of you who attended our earlier meeting with our earlier endocrinology meeting today, we discussed this issue in details. I guess this question will be easy for you to answer. We have a 45-year-old woman who is rheumatoid arthritis, who is referred for hypercholesterolemia and statin-induced myalgias. Creatinine kinase has never been documented to be elevated. Her physician has tried treating her with daily simvastatin, atorvastatin, and rosuvastatin, but unfortunately, she still has myalgia. So what do you give for this patient? You start atorvastatin plus CoQ10. You start rosuvastatin once weekly. You start red yeast rice. You start fish oil, or you secrete her for statin antibodies. Of course, this is a very important practical question on how to manage patients with statin-induced myalgias. This can be associated with elevated CK or even with normal CK. If the CK is more than 10 times the upper limit of normal, this is rhabdo, and these patients should never be given statin again. Of course, statin-induced myopathy has several types. The classical one is the statin-induced myalgia, but there are other types. They are called immune-mediated necrotic myopathy, and this is a more severe form that can even lead to death. And this form usually doesn't improve with stopping statin, and it progresses to respiratory failure. And but this type, if you recognize it early, can have benefit from steroids or IVIG or rituximab. So you actually have more than one type. One of the important things to remember is that those patients with statin-induced myalgia should always be screened for hypothyroidism and vitamin D deficiency. So let's see how you did. Most of you would give statin and CoQ10. Okay, some of you would give it once weekly. The best option actually is to give rosuvastatin once weekly. So one thing about combining atorvastatin on CoQ10, although it's been used by a lot of experts, but the evidence is not supporting that. And although some meta-analysis has shown that it is useful, the most recent data from randomized control trials show that it is not effective. And the best way is actually to give rosuvastatin once weekly, 2.5 or 5 milligram per week, rather than giving nothing. What about red yeast rice? Of course, this is a type of Chinese herbals. This is also an HMG-CoA enzyme inhibitor, so they work just like statin. And there had been some trials that has shown that it also reduces the cardiovascular mortality, but it's not yet been proven to use that. And given the fact that this patient has statin-induced myalgia, he is expected to suffer from myalgia with using red yeast rice as well. And red yeast rice is due to fermentation of the rice with a certain type of fungus. I don't remember the name, but it produces some material that acts as HMG-CoA enzyme inhibitor. Fish oil is usually used to treat hyper-TG, not hypercholesterolemia. While testing for statin antibodies, this is quite sophisticated, and this is used only in academic studies, and I don't want you to go into details, but this is useful maybe in cases where we have immune-mediated necrotizing myopathy due to statin, where you have an autoantibody against the HMG-CoA enzyme. I don't want to go into the detail, but this is important to remember. What to do, guys? Of course, this is useful in your practice. First of all, you try to change the statin. We have hydrophilic and we have hydrophobic. We usually try to shift from these. We use a lower dose. We know very well that pitavastatin, fluvastatin, and pravastatin are associated with a less degree of myalgia. So sometimes we go for that, but unfortunately in the market, we only have fluvastatin. And all of these indeed are only low to intermediate intensity, and they cannot reach the high intensity that we usually need in patients with diabetes. From the high intensity, we have atorvastatin and rosuvastatin, and both are associated with myalgias, although some would claim that rosuvastatin has less, but this is only, I think, from theoretical point of view, and the evidence doesn't show that or prove that. What to do if you have statin-induced myalgia? I recommend you check for thyroid and you treat, even if it is subclinical. You check vitamin D and you get the vitamin D level above 70. If the patient has still got myalgia, then you try to give him the minimal dose. I would usually try to give it every other day. If the patient doesn't tolerate it, you would give it once weekly. As long as the patient is on statin, it is better than nothing. We are reaching the end of our meeting. So question number 9, we have a 43-year-old man who seeks help to address his high cholesterol. And after experiencing an episode of angina, he had a positive treadmill stress test. So he has angina. On physical examination, he has papulonodular rash on both elbows and an orange-yellow linear xanthoma in the palmar creases, just like this one. Just like this one, Shabab. Just like D. So which of the following abnormalities is most likely to be present in this man? This is a bit tough, but I think it's interesting to give you a sense of the what lipidologists are looking for. So you have patient who has premature coronary artery disease, and he has features of dysbeta lipoproteinemia or type 3 hyperlipidemia. And the question is about the mutation in which enzyme, on which receptor. So is it ABCA1 deficiency, LDL receptor deficiency, apolipoprotein E2, apolipoprotein C2 deficiency, or overproduction of apolipoprotein B? Of course, all of these options are associated with a specific type of hyperlipidemia. And whenever you are encountering an abnormal lipid profile in a young patient or a premature cardiovascular events, here you can get the endocrinologist to tell you which type of hyperlipidemia does the patient have, although this is not always an easy job to do, as you may see in the cases that we present. I understand this is a very difficult question, but it's interesting to see that some questions are tougher than others. Okay, so some of you got it right, which is quite interesting. So apolipoprotein E2 is the correct answer here. Patients with type 3 hyperlipidemia or dysbeta lipoproteinemia or combined hyperlipidemia, we see them frankly not so rarely. It is estimated to be 1 in 100, but they are commonly misdiagnosed. These patients usually have a remnant TG metabolism accumulation, and they have elevation of both the LDL and the triglyceridemia, and they have these typical features of palmar xanthoma and eruptive xanthomas due to hypercholesterolemia and hypertriglyceridemia. These patients may have another precipitating factor, like let's say diabetes, alcoholism, use of OCP, So before that, they may be asymptomatic, but all of a sudden they develop some complications, and due to another culprit like using OCP, alcohol, or hypothyroid or diabetes. Another important review in this question is about Tangier's disease. Of course, this scenario can come up in the exam. They usually present with orange tonsils and very low HDL. So if you see a very low HDL and orange tonsils in the exam and hepatomegaly, you should think about Tangier's disease. These patients are at increased risk of cardiovascular disease. FH, we know that it is due to LDL receptor deficiency, and there are lots of types, homogeneous, heterogeneous, complete, and partial. But basically, they present with severe hypercholesterolemia and high LDL values with premature coronary artery disease. Of course, what we see is the heterozygous type who present with premature coronary artery disease. Apolipoprotein C, this is important to remember. This is a cofactor in lipoprotein lipase, and it's associated with hyper-TG, and it is one of the causes of severe hypertriglyceridemia. Familial combined FCH, this is quite similar to this beta lipoproteinemia, where patients have overproduction of apolipoprotein B2. ApoB2 actually is the atherogenic lipoprotein, and we measure it sometimes, and we can have an idea about it from the non-HDL value and the normal lipid profile that you can get from any lab. So it is not something that is from another planet. FCH is commonly inherited and is seen mainly in patients with type 2, and they have also elevated LDL and TG as well. And also they share the findings with palmar xanthoma and tubular reticuloxanthoma characteristics of this beta lipoproteinemia. The last question for today, we have a 30-year-old man who presents to you with the following lipid profile. Total cholesterol is high, LDL is high, HDL is all right, TG is normal, and he has the following findings in his skin. I hope that the image is clear to you guys. So you have this, and we call them, what do you call them? Can anyone answer me in the chat, please? If anyone has an idea, what do you call these? Anyone has an idea? I don't know. I don't see the chat. There's some problem. I don't know.
دكتور طلع الشات عندك اني واضح.
Yes. Now I see. So you think this is tuberous xanthomas? Yes, okay. Of course, this is tendon xanthoma here seen in the hands. So these are characteristic of hypercholesterolemia. You ask about his family history, and he tells you that his father died at the age of 70 because of myocardial infarction. And his mother is alive, and she's all right. She's 62 with low cholesterol. And his three brothers are reportedly, he has one of them who has high cholesterol. His TSH is normal. So what do you think is the most likely genetic defect? Is it an LDL receptor deficiency? Is it lipoprotein lipase deficiency? Is it ApoC? Is it ABCA1 or is it ABCG8? يعني السؤال عمودي سهل عليكم شباب. lipoprotein lipase هو عبارة عن familial hypercholesterolemia. lipoprotein lipase deficiency هو familial hypertriglyceridemia. ApoC2 deficiency أيضا hypertriglyceridemia. وال deficiency of ABCA1 هو Tangier's disease, وال ABCG8 هو cytosterolemia. cytosterolemia. السؤال الأخيرين آخر سؤالين اليوم شوية بها genetics a bit difficult but it's important to get an idea about the genetic hyperlipidemias. It is not always statin and go ahead. Okay, there is a wide distribution of answers, but unfortunately the correct answer got the lowest number of votes, and it is the ABCG8 here. Of course, this is quite difficult, but I thought it would be interesting for you to get an idea about this scenario. So you see a tendon xanthoma, so you think this is FH, but the history is not consistent with FH. He has negative history, and the values are actually not as high as you would expect in patient with FH. FH is an autosomal dominant, and as you can see that his family history is negative. Lipoprotein lipase and ApoC cause hyper-TG. ABCA1 causes Tanger's disease. And as I explained a few minutes ago, these patients present with orange tonsils and very low HDL values. This case is actually called beta cytosterolemia. This is due to defect in ABCG8 or ABCG5, but it's not important to remember the name. It's important to know that this enzyme is a transporter in the intestine that effluxes the absorbed plant sterols in the lumen. So this disease actually results from plant sterols, which are normally not absorbed. But what happens is that because this enzyme is not present, so these sterols become absorbed because this enzyme effluxes the absorbed sterols. effluxes يعني يدفع لللومن مرة ثانية. So if this enzyme is deficient, there's enhanced absorption of the plant sterols, وبالتالي يصير عندهم hypercholesterolemia, just like FH, and there's an increased risk of cardiovascular disease. And all they have to do is that they need to stop using plant sterols, and these patients would benefit from using ezetimibe because it prevents the absorption of lipids and sterols. So by this, guys, we finished our lipids review for today. We got 10 questions about diabetes, 10 questions about lipids. I still prepared another 10 questions for diabetes for you if you want more, but maybe you are tired. So if you want, we continue. If you want, we make it into another lecture of diabetes and lipids. And we still have something to say about the male and female reproductive system. So if anyone has a question, he can raise his hands or he can write it in the chat. I'll be more than happy to answer your queries. دكتور عباس، إذا تشوف الزملاء مثلا شو يحبون يعني يكملون أو
يعني ما أقدر أسوي بولز إلا إذا هم يكتبون لنا بالشات.
ما عندنا بولز. أوكي، إذا شباب ننتظر يعني الفيدباك مالتكم على الشات، نشوف من الأغلبية تريدون نكمل نرتاح. أنتوا يعني take it easy. إحنا we have time هسه بعد امتحان صار مال الجماعة، ف we can schedule another meeting if you like.
عمي إذا يحبون ممكن نسوي سلسلة أخرى، يعني مثلا بعد فترة 3 أسابيع نسوي سلسلة أخرى، يعني هو ممكن الليبيد.
يعني احنا الدايابيتس والليبيد still there is a lot of to cover حقيقة. we can continue with the diabetes and lipids more. بقية الأشياء I think it is beyond the scope of internal medicine. بس ما أعرف الشات مدى يظهر عندي دكتور عباس، ما أعرف شنو القضية.
دكتور هو حضرتك إذا انهي البرزنتيشن حتى شوي تتغير.
خلي أشوف. ستوب. طلع عاشت إيدك هسه تمام. Okay, so another meeting will be great. For another meeting, okay, يعني جماعة يريدون another meeting even better. إذا هيك إن شاء الله، يعني إذا ما عندكم سؤال شباب، يعني ننهي الميتنج. سعد دكتور عباس اذا عندك شيء تحب تضيفه يعني اكيد اشكركم مجددا على
الله يحفظك.
الفرص اللي توفروها. يعني اولا نلتقي بزملائنا وايضا اصلا دا استفاد هوايه بتحضير هاي الاشياء، لانه يعني اشياء ما مراجعها صار فتره، واتمنى انه الشباب هم اللي يستمتعون اكثر مما يعني يحسوها فد واجب او لازم يسوون. واي فيدباك يعني is welcomed. احنا هنا يعني is a friendly environment. فيعني اي شيء تحب تضيفه دكتور عباس يعني احنا كلش سعيدين.
احنا بس اللي نحب يعني احب اضيفه انه اسمع من يعني الشباب زملائي انه اذا اكو فد موضوع معين، اكو فد تكنيك معين يحبون نغيره بالبرزنتيشن. يعني هاي ثاني سلسله ويبينارات، احنا اول شيء سوينا على الريسبيراتوري وثاني على الاندوكراين.
اي يعني هم اذا يحبون مثلا موضوع ناخذه from A to Z هم ممكن، يعني مو MCQ like presentation، بس اتصور هيك نغطي اكثر يعني مواضيع بالMCQ من بس يعني اذا يحبون مثلا ناخذ موضوع from A to Z هم ماكو مشكله يعني. بس اعتقد الMCQ شويه اكثر entertainment بيها. اذا ما عندكم شيء شباب يعني اتمنى لكم ليله سعيده، ونلتقي ان شاء الله يعني بالاسبوع القادم
ان شاء الله دكتور. شكرا على وقتك.
على خير. لا العفو، مع السلامه. في امان الله.
مع السلامه.